on the 11th of September 2001, I was in the Bronx doing endoscopies when the first plane hit the World Trade Center. We know what happened after that. Many people died, some survived. There was one difference between the ones who died and the ones who survived. Can you guess? When the plane hit, many people were told to remain in their seats and continue as usual because they did not perceive a risk and that everything is being taken care of. Then there were others who had a sixth sense that there is something not right about this picture. If a plane has hit your building, it makes perfect sense to take the fire escape and get out of the building as quickly as possible, regardless of what people around you are telling you. So there were two categories of people. There were people who listened to the most comforting words. I call that confirmation bias or wishful thinking. And then there were people who were able to anticipate what was happening. They made it out alive. They didn't go with comfort opinion. For surviving any emergency, anticipation is important. And anticipation, while a pandemic is a 9/11 happening in slow motion, sometimes we take it too slow. But we need to stay 2 steps ahead, and you will agree that to stay 2 steps ahead of any game, we need good data and networking. When the pandemic hit India, at Cochin, we had an elaborate network of healthcare providers who were doing all sorts of community engagement. We empowered doctors. We called doctors regularly for our meetings. They were virtual. And at Cochin, we have the longest running weekly Tuesday COVID meetings. Our president, Dr. Maria Verghese, is in the audience, and she chairs it now. I've been chairing it for 2 years. We've sent out so many guidelines to doctors, to policymakers from all around the country and from around the world. All this from collective brainstorming. We might recall that in 2020, there were no vaccines. We had hardly any idea what the outcome was going to be like. But we stuck to the basics. We knew that if a large number of people got sick in the community, and if they all rushed to what is called the apex center, that is what I call the top of the Christmas tree would collapse. So we took time and effort to empower the mid-level hospitals, the single-man clinics, primary health centers, and to empower home treatment. As you know, most patients with COVID-19 do not need to come to the hospital. But unless you empower home treatment, unless you instill confidence in the ASHA workers, all of these individuals will come running to the apex center. And the sickest of the sick will not get treatment. So this is the secret of success, if you will, by empowering different segments of the healthcare system. And that was what led to flattening of the curve. Prevention of complications is as important as was discussed here by my previous speakers. I'll give you an example. I'm a road safety trainer. I train on fire safety as well. So we knew that the pandemic, with excessive use of oxygen and rapid turnover of cylinders and in the ICU, there is a risk of fire. We predicted that Fires will definitely happen, and they did happen in India, many parts of India. You see these breaking news, 12 patients and 2 nurses dead. Sometimes they flash on our mobile phone screens. These are tragedies that are eminently avoidable. It was not a single fire. There were dozens of fires that occurred in hospitals throughout India. In Kerala, the count was 0. These are the list of hospitals, the partial list of hospitals that had tragic fires. Another tragedy was the death of healthcare workers. And in May of 2020, from Cochin, we published the first series of doctors' deaths in India. We said over 100 doctors had died, and people said we were making these numbers up. Yes, we also sent out custom guidelines for healthcare workers. We wrote to nurses how to protect themselves in April of 2020, when most of the world had not even known what to do. If we take the counts of the number of healthcare workers who died all over the country, we don't have an exact number, but an enormous number of people lost their lives, especially in the first half of the pandemic. Kerala had the fewest. It is because of early empowerment. Our healthcare workers, our nurses, our single-man clinics, our hospitals knew what to do. This was not the case in some other parts of the country. Many doctors died in their 30s and 40s in 2020. We are on a forward timeline, and at this point, I'll tell you what is trending. When people were pushing the herd immunity narrative, one of the biggest lies of the pandemic, some of us wrote that it is a myth, and now reinfections are trending. The graph you see there, the blue lines represent reinfections. This is a graph that I've taken out from the Washington State in New York in public domain. You can see the red line at the bottom represents 2022. As we go forward on a timeline, we're going to see a lot of reinfections. And if you ask me, what will be the outcome of repeated infections? I'll say, I do not know. This brings us to the question, how well have the vaccines done? If you look at the graph, this is the CDC's official death statistics by graph. I have divided it into 3 age groups. There is, to the left is 18 to 49, the middle is 50 to 64, and to the right is 65 plus. The black line, the black curve, represents unvaccinated, and you can see the blue lines at the bottom represent vaccinated 2 and 3 dose groups. You can see that whether you're 2 or 3 dose vaccinated, your death is 0, literally 0, because 9 out of 100,000 to me is 0. It is such a minuscule number. If you look at the age below 50, there is no difference in the death rate between vaccinated, unvaccinated, or boosted. If you look at 50 to 64, yes, you can see a difference. But in the 50 to 64 age group, look very carefully at the 0 line. There are 2 lines there at 0, 2 dose and 3 dose. Yes, below 65, it makes no difference. Above 65, it makes a marginal difference. 9 out of 100,000 for 3 dose, 2 per 100,000 for 3 dose, and 9 for 2 dose. That difference is almost like the difference between both your hands. Well, if you measure the size of a hand with a fine scale, you might be able to tell a difference. But if I look at my hand, they look the same. So tiny differences get exaggerated by scientific publications. Don't be misled by that. I'll spend a minute focusing on this graph by Dr. Robertson from England. I do a lot of my work on Twitter. I have over 12,000 tweets, pure science on the pandemic. You're welcome to see it. This is one of them. If you look at the tallest bar graph, you scroll all the way down, that's the number of deaths by age group. Different colors represent different age groups. What is remarkable about that picture is what I have handwritten at the bottom. The age groups below 50 are represented at the bottommost graph there. In other words, almost all that you see are over 50. Yes. Over 99% of deaths in the pandemic are in the above 40 segment. If you look at Kerala's figures, 97% of our COVID deaths are over the age of 40. And India, 75% of our population is below the age of 40. In other words, the vast majority of our deaths are occurring in just 25% of the population, and they need special attention. That's the message. The trend now is to boost. If you look at the Western literature and the tweets of celebrity Western doctors, you'll see if the earth does not quake today, it's because of boosters. If a volcano does not erupt today, it's because of boosters. If you look very carefully and ask yourself this question, after the second dose, are the third and fourth dose making any difference? We call it the principle of diminishing returns. And yesterday in the Wall Street Journal, Dr. Philip Cross, who was the deputy director of the FDA's Vaccine Research Committee, said the following. He said, 2 doses are enough unless you are at high risk. You're welcome to read his piece in the Wall Street Journal yesterday. This I get asked quite a bit, and I say I don't know. But it's important to look at the genomic tree of this virus. The variants that are coming are not like iPhone upgrades. One phone does not lead to the other. These variants arise from remote parts of the genomic tree. Nobody has any idea where the next one is going to come from. We know it will come. And by default, it will be faster spreading. It will be immune evasive because that is the nature of the beast. There is no stopping it. Make no mistake, the virus is in the driving seat here. In all humility, we must acknowledge that. This is a tweet that I put out last year from a paper in 1989, published in the Journal of Epidemiology and Infection. This is something called cyclical viral diseases. COVID-19 is just another cyclical viral disease. There are so many more of them around. They come every year, and it can be cyclical or seasonal. The point about COVID-19 is it is not seasonal. In other words, it's not going to come on June 1st or September 1st. It's not. It will come when local immunity wanes and sufficient time gap is given for development of the next variant, regardless of where it develops in the world. I get this a lot. Where are we now? Can you tell us where we are? If that is the pandemic curve, many people think we are here. If you ask me, I will say, where are we really? I'll say, we are here. A few challenges ahead. How to improve room ventilation. This is a large room. We are at low risk for getting an infection. It's okay to take off your mask once in a while. If you're sitting in a bar and a lot of people are talking, wear a mask. In a hospital room, how many air exchanges are being done every hour? Are our systems able to replace the air with outside air? So these are questions that face us as healthcare providers. What is the ideal PPE? How do you juggle the constantly fluctuating staff requirement? How will we switch back to our cancer screening programs? What will happen to all those cancers we missed? Elective surgeries that got postponed. How do we cope with staff sickness, long COVID? For that, we need to continue to work together because none of us is as smart as all of us. Thank you.